Oh, that we didn't do that. You told me to start right away, and I did.
We're starting, okay, one second.
Yeah, we're live, we're good. Go ahead.
Welcome to the fourth and final summer learning series. All summer, we've been bringing you back-to-back hits, talking about what we do at the Denver Prevention Training Center. My name is Tai Edward Few. I use he, him pronouns. I'm the associate director. In our first episode, we talk about what we do at the Denver Prevention Training Center with Helen Burnside. In our second episode, Kiana Stallworth joined us and we talked about responsible data practices. In our third session, we talked about targeted universalism with Bev Wasserman. Today, I have my friend and colleague, Dr. Sarah Rowan here. We're going to talk about HIV, Hep C, and substance use. Dr. Rowan, introduce yourself.
Okay, thank you, Ty. Sarah Rowan, she, her pronouns. I am an infectious disease doctor at Denver Health. I'm the medical director of the Prevention Training Center as of January 2025, which has been a huge privilege. It is so fun working with the PTC and the amazing, talented people there. I have a background in research in hepatitis C and HIV engagement and care, kind of looking at interventions across the continuum of care to promote better health outcomes.
All right. As we talked about in our session one, we're going to spend some time looking at syndemics, and that's going to happen today. So today we're going to have a very conversational approach to this topic. We're going to share some PowerPoints, but we're just going to talk amongst ourselves, and then at the end we'll have some time for questions. So before we get started, Dr. Warren, tell us a little bit. Define syndemics, because it's a big word. We don't really talk about it every day in public health.
So I'm going to go ahead and show a slide that
Yeah.
defines syndemics, if that's okay. And I'll just use the slides for the conversation. So this is kind of a recent talk, and it's kind of a nice example of some of the things that the PTC does, because this is pulled out a few high-level slides from a talk that I recently gave about HIV, Hep C, and substance use syndemics.
Okay.
There are all sorts of syndemics, but I wanted to kind of highlight this for this particular talk. And so, we know that HIV continues to be prevalent and a major public health issue in the United States and globally. This map just sort of shows the distribution of new cases in 2023. And of those, many were among people who use substances, either acquiring HIV through injection drug use, which is a direct route, or through sexual activities that they might not have done had they not used substances, or substances can, affect treatment. So HIV and substance use is already kind of a syndemic. And then, we talked about 87% of people living with HIV not knowing their status. So when we think about that gap, that's a huge opportunity to leverage the fact that people access care in different places.
Right.
And so we can really acknowledge and lean into the syndemic of substance use and HIV to improve testing. A couple more slides and then I'll get to the definition of syndemics. Hepatitis C also often travels in the same circles as HIV and substance use. Yeah, and it's a total Venn diagram. And so let me just go to the syndemics slide. So syndemics are when two or more diseases or health conditions cluster and interact within a population because of social and structural factors, leading to an excess burden of disease and continuing health disparities.
So let's stop there and just kind of break this definition down. So when we talk about social and structural factors, what are those?
So there can be homelessness,
Okay.
they can be poverty, lack of insurance, adverse childhood events. It can be stigma. It can be a whole variety, substance use. And those things really can interact and make it harder to deal with each one when there's an overlapping influence of these challenges. And so those are some of the social drivers of health. I don't like to use determinants anymore because our health is determined by so much more. But these are things that can influence
Correct.
health. Yeah.
And we talked about these things in episode 2, episode
Mhm.
3, and again, episode 4. These drivers of health are things that are happening in our communities. They impact people's ability to access care, to get high quality care, or
Mhm.
even prioritize their care. Okay, so that's when we talk about some syndemics, we're talking about 2 or 3 clustering in the same community. Can we go back to that definition
Yeah.
just a little bit, just to make
And
certain everyone's
Tai, that was such a good description of the way these social challenges can affect healthcare.
Yeah.
Yeah.
So then they lead to an excess burden of disease and continuing health disparities. And so we are seeing that every day. It's not just with HIV, we are seeing it with other health conditions.
Mhm.
And the reason that we're talking about it is because if we think about approaches, we can address some of these things at the same time and not silo out our health, correct?
Exactly. There's so much room for synergy with our approaches. So, leveraging time that somebody engages with healthcare for one reason, we could also address other concerns. And what I have found is that what our patients, if you're thinking about healthcare, what their concerns are may not be the same as their provider. So really, like, it's a great opportunity to join forces and work together for really good health outcomes that are mutually sought after
Yes.
and beneficial. Yeah.
Okay, great. So then take us to that next slide. Just want to make certain that everyone understands this. These are the social and structural factors that are impacting our health. And so these are not an exhaustive list, but these are some of the things that we're going to be talking about today. And these are the things that are really driving people's ability to access care,
Mhm.
get quality health care, or even prioritize their care.
Exactly. And we'll see that, with substance use also comes increased hep C rates because of the transmission risk.
Yes.
And similarly, we've seen certain sexually transmitted infections travel with substance use.
Yes.
Or HIV. And so that is really a syndemic because it's 2 overlapping conditions. We're seeing increases in syphilis among people who use substances, and it's not necessarily that there's one clear reason for this. But as you can see in this Venn diagram, you may have 3 different diseases, and there's a place where they overlap, and that is the way that social challenges are driving an increase in certain infections or non-infectious things. Like
Right.
we've even seen syndemics with like diabetes and poverty and
Yes.
and tobacco use. And so it's really this Venn diagram of overlapping social issue challenge and then multiple diseases that overlap.
And we need to understand this is not about blaming anybody. These are happening in people's communities. This is what is happening in the world that people are living in today. And our goal is to get healthcare providers to understand that and to engage with their patients, with communities in a way that removes the stigma and the blame.
Yes, absolutely. So I think that the stigma is also so multifactorial.
Yes,
There's stigma around substance use, and it's only been in the last few years that people have begun to realize that, this is an illness that we can treat.
Yes.
And so it shouldn't be stigmatized, but when things get stigmatized, people are less likely to seek care.
Yes.
And we have really good care, and people recover, and they lead long, healthy lives. And even if people don't, we're losing our light. Even if folks don't quit using drugs, they still have really valuable lives. And so if we can look at people holistically,
Right.
and not have our own healthcare stigma and bias, then we can really improve health outcomes on many fronts, and not just saying like you have to do it our way, our way or the highway. So I think that acknowledging stigma and bias is really important for improving health outcomes in these areas of overlapping illness.
And to underscore that substance use is an illness. There is no judgment about that. As healthcare providers, healthcare centers, health departments, we have to have this policy and this mindset that does not abuse people for an illness that they are dealing with.
Absolutely.
Right.
We're not going to shame our way out of any epidemics, any syndemics.
Shame does not work.
It doesn't work. And if it worked, we wouldn't be where we are now because there's been plenty of shame to go around. But being positive and acknowledging that we all have challenges, we all have things that we wanted to do differently and didn't. There's more than willpower at play here. I think that's just really important to have that humility as a healthcare provider and healthcare affiliated person, that this is the way to move forward in a way that's really shared decision making and honoring each person as a really complicated and important holistic individual.
Whole person care means that you are thinking about all of those different things. Okay, I'm slowing you down. I just wanted to make certain that
Oh
we
yeah.
underscore that. Even though Game of Thrones did tell us that shame does work in some situations, shame is not a preventative cure.
So, just the kind of pointing out with these syndemics, Hep C is prevalent around the world. And if we silo, we don't realize like how big a deal Hep C is when we're thinking about HIV, but there's quite a lot of overlap. Many people have both, but also these are both really important viruses that affect a lot of people. Hepatitis C is responsible for more infectious disease related deaths, like reportable infections, than all other reportable infections combined. So I spend a lot of time trying to raise awareness about hepatitis C, particularly because it's curable now.
Yeah.
So
I remember when I was a younger person doing Hep C work, we didn't talk about a cure for Hep C, and now
yeah.
we're able to talk about a cure for Hep C.
It is amazing. So, just a reminder that most of the cases of Hep C are driven by shared injection equipment because it's mostly a bloodborne pathogen.
Okay.
Whereas, with the opioid epidemic, more people were using injection drugs. People also use injection stimulants. And when they share injection equipment, then there's a chance for blood-to-blood transmission. Hepatitis C is very hardy on surfaces, so it lasts on injection equipment. And that's why there's more Hep C among people who inject drugs than HIV, because HIV is inactivated in the environment much quicker. But injection drug use is still a factor in HIV transmission. So, we've seen sort of a plateau over the last few years in injection-related HIV transmission in this country. It's just a reminder that, this can be a direct transmission source, but then there's all those other social drivers that
Yes.
affect things as well. And I'm going to pass through this just to say HIV, there's a variety of transmission factors. But this kind of shows some of the overlap between HIV and substance use in this slide. About 13 to 30% of people with HIV may have an alcohol use disorder. So we need to be educating ourselves about the effects of alcohol and alcohol use disorder on risk for infection and treatment outcomes. And just to say that a lot of substance use is common, and so we don't want to ignore it.
And before you move away from that
Mhm.
PowerPoint, I want people to read the language that you're using here. We talk about alcohol use disorder. There are many terms in popular vernacular to describe people who are suffering from alcohol use disorder. This language that we are using is language that is avoiding stigmatizing. We have a campaign here at
Mhm.
Denver Health called Words Matter. And what we are trying to do is get healthcare providers to understand the language that you use will frame the interaction between you and your patient. And the language that you are modeling for us is the language that we want providers to use so that they understand that.
Yes, I think that alcohol use has a whole range of effects on people, and there are people who have some challenges, some alcohol use challenges, alcohol use disorder, huge range. This is not a monolith by any means. But yeah, we have really moved away from defining people by an illness into person first language, where it's a person with alcohol use disorder, a person with diabetes, a person with HIV, rather than defining somebody by a challenge that
By
they
a
have.
health condition, yes,
Mhm.
exactly. Thank you.
Yeah, and then this, I think when we think about syndemics, the one that comes to mind for substance use and HIV was the massive outbreak that happened actually 9 years ago now. I don't know if
Yes,
you remember that.
I remember that.
Yeah.
I remember waking up to these statistics coming out of Scott County and
It
talking
was a while
about
ago.
what that really meant for people. And I was at a conference last month and I was able to speak to someone from Scott County who was talking
Mhm.
about that they are facing the same issue again today.
Yeah, and actually a lot of states are facing increases in HIV among people who use drugs, inject
Mhm.
drugs. Um, and there have been a bunch of these outbreaks. So this is kind of a classic syndemic. And I think what didn't get as much attention was that 90% of the people from that outbreak. So this, the graphic shows 142 cases. That was the initial news report. When all was said and done and the dust settled, they found that there were 215 cases of HIV transmission associated with this like network of folks who were injecting opioids. 90% of those folks also got Hep C.
Yes.
So like if you didn't pay attention to that, you would miss the opportunity to cure
Yes.
Hep C in those folks, and vice versa. If you only tested for Hep C, you would have missed the opportunity to do HIV testing and get people into care. And there was a lot more Hep C that was transmitted as well. So we have to think holistically about preventing transmission of these viruses
Yes.
and preventing substance use disorder and identifying it and treating it.
And this is not just a problem happening in the United States of America. Your slide says that outbreaks are also reported in Athens, Greece, Tel Aviv, Israel, and Dublin, Ireland. So this is not just us.
No, it's a global problem. I think what's interesting about injection drug use in HIV is that because HIV is so much less prevalent than hepatitis C among folks with who might share injection equipment, sometimes it gets deprioritized, understandably. I mean, people have a lot going on, and Hep C, they're more likely to find Hep C, but HIV happens in clusters.
Yes.
So you have to be vigilant that there could be an outbreak of HIV among people injecting drugs. And so we cannot forget about it, even though HIV is more often transmitted through sex.
Yep. All right.
And other things, I just want to mention homelessness. Homelessness among people with HIV has been a challenge, and about 9% of people with HIV are experiencing homelessness. So when we think about ending the epidemic, we will never get there if we don't address the challenges of taking care of yourself with unstable housing.
So let's just spend some time here so we can break this down because this seems to be an issue people don't understand. So why is homelessness, what is the intersection between homelessness and HIV?
Yeah, I mean, I think there's many reasons people get HIV, and homelessness may predispose to that risk if people are, especially if people feel like they need to do transactional sex for safety, for shelter.
Yes.
If there is an overlap of substance use, people may acquire it through injection drug use or through using substances and then having higher risk activities like multiple partners without condoms, without PrEP. So there's that risk. And then when people are experiencing homelessness, it is hard to find a place to store your medications.
Yes.
Medications can get stolen.
Yes.
You have to go to a lot of places to get your paperwork, your food, appointments, and taking medications may slip through the cracks. So there's just a lot going on. Yeah,
right.
you may lose your insurance coverage because you didn't have the tools to go online and renew it. I mean, it's just so many factors that can make it challenging for people with HIV to engage in care if they're experiencing homelessness.
And so this is something that we really want people to understand. So this is another driver. You talked about having multiple partners and negotiating sex. Negotiating safer sex is difficult if you feel like you're not equally powered in that negotiation. So also if you don't have a place to store your medication or a regimen to know at 10 o'clock I do this. If you are unhoused or experiencing a loss of housing, all of that goes away. So this is another driver, and we need people to understand this because it then impacts how people then are able to, when we look at this PowerPoint, when we're looking at, especially around medication, housing, your ability to have stable housing is linked to decreased viral load, right?
Exactly. And I have a slide about that. I'm going to pass through transmission because we already have basically talked about that quite a bit. I'll just say for anybody out there who's an artsy person, this is my drawing of a liver. So I encourage you to lean into your creative self because this is what nourishes us in healthcare.
Before we do that, Sarah, you are an artist in many ways. I know about the drawing. I also know about the other things that you do. Just basically give us a little bit of insight into who you are as a person, like your other
Oh,
creative outlets.
oh, okay. All right. Well, we'll leave my liver up there while I talk about myself as a holistic person.
Right.
I'm married. I have two boys, twin boys. They are in the 7th grade, navigating middle school. Not the easiest thing. We see you, it gets better. I have a couple dogs. I grew up in Oklahoma, moved around, military kid. In my role professionally, I do work in the medical school as well, work with PTC. So I love teaching, I love research, and I love clinical care. And that's why I feel like the medical field is awesome because you can do all of these things and work with people who, teach you so much. And then, yeah, my hobbies, I like to do Colorado outdoorsy things,
Right.
but I do love art. And over my life, I'm in my late 40s now. I have always come back to art. And I think it's just, it really, I think that having a creative outlet is just really protective of stress in a lot of ways. So,
And
yeah.
maybe in series 2 for the summer learning series, we'll talk a little bit about holistic care and encouraging those who work in healthcare to really kind of preserve their peace. Okay, thank you.
Music, exercise, comedy, whatever it is, do it. So kind of thinking back to transmission, I just want to acknowledge that, hepatitis C can be perinatally transmitted as well as HIV. So this is affecting not only adults and adolescents, but also the potential for perinatal transmission. Hepatitis C can be cured in children, whereas HIV, as we know, is not curable. But again, this affects our OBGYN colleagues, our pediatric colleagues, and it affects infants and children. So these are really, really important topics. I like this slide because it's kind of brings in all of the potential partners, not all of them, some of the potential partners for HIV and Hep C testing and treatment. So substance use, treatment services, public health, correctional settings, emergency departments, primary care, all of these places are very high yield for HIV and Hep C screening and can also offer treatment, especially for hepatitis C and to a degree for HIV. And if not treatment for HIV, at least referral for HIV.
Right. You can get started on the art regimen.
Exactly. And if anyone out there works in substance use, I think this is a cool slide because this is best practice from our substance use treatment center at Denver Health. And they do an intake lab, one blood draw. And they really have thought a lot about how to optimize that one blood draw when people have intake for substance use disorder treatment. They get a CBC, hepatic panel, check for Hep A immunity so we can give the vaccine if people aren't immune, check for hepatitis B infection, and check for hepatitis B immunity. And if there's neither, then we can give the hepatitis B vaccine and prevent hepatitis B.
Yes.
We have a newer vaccine that's very effective. They screen for Hep C and they do a reflex test. So anybody who's antibody positive for Hep C or HIV automatically reflexes to a viral load. And they do syphilis screening. So this, I think, is it's great that they're able to do this holistic one blood draw approach. I'm not going to do too much about treatment considerations. I'm not getting into the weeds about it. I used AI to make this figure of the two hands holding cards. So thank you, AI, because I wanted, on the one hand, to say that substance use disorder can contribute to adherence challenges, environment, housing, memory, even. On the other hand, we have excellent data that people with substance use disorders can have amazing outcomes for HIV and Hep C. So do not withhold treatment because somebody is in any stage of substance use disorder. They can do great. But on the other hand, we don't want to ignore the fact that substance use disorder can create challenges. So, just the two hands of that situation. We recommend vaccines for people with substance use disorder, depending on their personal considerations. So kind of matching, what the person is going through, what their background is to what vaccines are indicated. And we have a vaccine clinic at our substance treatment, clinic. So that's really cool for people. It makes it so convenient to get all their vaccines. And then I'll just mention here some public health partnerships. And so we've got integrated care models. I think the next one, yeah, we have 2 integrated care clinics at Denver Health. Public Health Use Disorders Clinic that Dr. Hermione Hurley started, and now Dr. Hanan Braun is running it. And this is a place where people can go for really their HIV primary care and also get Suboxone or other substance treatment. And then we have this really cool clinic run by Dr. Kelly Hawkins called the Direct Access to Care Environment. It is very low barrier for people with adherence challenges. And these things have both been really helpful for people with substance uses.
When you say low barrier, what does that mean for people?
So they have drop-in appointments.
Okay.
They have a dedicated ID physician and case manager. So people who are really helping actively get housing vouchers, get on, we don't have a lot of housing, but at least we can optimize your chance of getting it. Get access to food, stay up to date with their ADAP enrollment. They have gift cards. They kind of look into contingency management and do it as possible. They have these milestone incentives for viral suppression. And there's really interesting data about this kind of model. And Dr. Hawkins has shown amazing outcomes for people who've really struggled to get their HIV under control. And back to stigma, I mean, most people with HIV do great and they take 1 pill a day or they get an injection every other month and they have viral suppression and they have healthy lives, and HIV is a small part of it. There's a small amount of people who have big adherence challenges, and this kind of model has been really life-changing for them.
And an adherence challenge doesn't mean that we stop. It just means that it's not a problem. We can figure it out.
Yeah, exactly.
Yeah.
Exactly. These were some considerations, just to optimize care. Trauma-informed care is here at the bottom. I don't know if we'll be doing a session on trauma-informed care, but
we could be doing that next summer.
Our partners do that a lot.
And we at the PTC, we have several courses in our capacity building assistance program that talks, and our regional program that really talk about what does it mean to have a trauma-informed care perspective. Our Center of Addiction Medicine also has a course for that as well. Yeah,
and it's excellent. It's, even though you kind of think, well, I kind of get the idea just even from the name, there's so much to learn. So the courses can be helpful, but you're really just orienting ourselves to the concept of, you are not your experiences, but your experiences shape you,
Right.
So this is the no wrong door approach to substance treatment at Denver Health.
Center for Addiction Medicine, yes.
And they've just been amazing partners in optimizing care for people with any kind of addiction or substance disorder or substance challenge even. And so we have a couple different clinics where we offer both HIV, Hep C, and substance treatment care. And then we have a lot of places where we find that they can be the door that opens, and then we connect people to where they need to be.
Exactly. No wrong door.
No wrong door. This is a really neat model out of Boston, Healthcare for the Homeless in Boston. They were able to look at the amount of people who had risk for HIV, elevated risk. I mean, obviously everyone could get HIV, but we're at elevated risk, and they found that very few people were using the HIV prevention medications, PrEP.
Yep.
They did a really dedicated, concerted effort, and they got 239 people linked to PrEP and 152 people, and this is people experiencing homelessness. So it's a lot of potential.
That's a lot of potential. Yes.
HIV, averted, and this PrEP, Together We Can Beat HIV. This is something that one of the clients created. Kind of neat that it sort of resonates. This was the image that the community group chose, and I think I love that. Housing, again, with this syndemic, we cannot underestimate the effect of housing. There's so much data to show that when people get housing, any level of housing, they have better outcomes. This picture is from Dr. Ed Farrell at the Colorado Coalition for the Homeless. I mean, this is where some people have spends the night, and it's really hard to deal with life in that situation.
It's hard to prioritize medication when you're living in that situation.
And I won't go through too many more slides. I just want to mention that when it comes to syndemics, people who inject drugs are, and people who use any substances, smoked or consumed, are also at risk for serious bacterial infections like abscesses, cutaneous abscesses. The picture of the palms is secondary syphilis. So, remember to address these issues with your patients and your clients. And then we really can't emphasize the risk for overdose with the really potent drug supply that's out there right now. This is from a wall in one of our community partner sites, and these are all people who've died of overdose. So every opportunity that we engage in any level of syndemic care, we should be offering naloxone.
Yes. And this is what public health does. We need people who are public health practitioners to understand the breadth of what we're doing here. We are here to help the community with better health outcomes, which means that we care about all of these things here.
Exactly. Exactly. And you can't necessarily do everything every visit. And so we have to give each other grace that we're doing our best. And we have to meet patients where they are and read the room, and also be aware that every opportunity could be an opportunity to address all of these factors and more.
And that was a little bit about what we talked about last time in episode 3, when we talked about targeted universalism. It's thinking about what an aspirational goal is and coming up with plans to move a community towards that. So tell us about these national campaigns.
Well, I just mentioned, we talked about stigma before, and this is one of my last slides, and I just wanted to say that I think that public health has a great role in bringing community together to explain how stigma manifests in their lives, and how it could be addressed and minimized. And so this was like one kind of community-driven campaign. There's so many examples of this, but just again, to be aware of how stigma exacerbates syndemics.
Right. And our role as public health is to model ways to eliminate stigma.
Exactly.
Our role is not to model how to hype stigma, but to eliminate stigma.
And I think about words matter and language, and we in the medical community have probably worsened stigma over the years by the words that we used. And so we just need to have the humility to say, oh, I didn't realize that way of saying something was making things worse, or people didn't want to go to the doctor because they didn't like the language that you used, because then that kind of led to a feeling of a different treatment.
Right.
And so we need to be able to change.
Yes.
And it's okay. And we've all made mistakes and learned, and what was commonly accepted at one point isn't anymore. So just being open to that feedback from community and our peers and each other to, always be trying to decrease the stigma that we are accidentally or intentionally, hopefully not, promoting.
One of the goals of the Summer Learning Series was to create within public health practitioners this desire to be lifelong learners, beginner's mind, which is a Buddhist practice. Something that we've talked about in episodes 2, 3, and 4 is that it is okay to learn from our mistakes. In fact, that's what happens. You should be learning from mistakes, not repeating them.
Yes, part of the life experience.
Yes.
So we have ending the epidemic goals for HIV. We have ending the epidemic goals for hepatitis C, and really the WHO is looking at viral hepatitis overall. This is kind of the schematic for ending the hepatitis C epidemic from the National Academy of Science. So we have global and local. We have international ending HIV goals. And I think that the way to get through is to acknowledge the role of syndemics, overlapping challenges. Getting a little redundant here, but I think that that's really an opportunity to really get over the plateaus that we've seen. We have medical advances that have dramatically improved HIV care. Amazing. We have curative Hep C treatment, 8 to 12 weeks, 1 or 3 pills a day, just once a day, minimal side effects. curative, no more virus, you can't pass it to anyone else, you don't get cirrhosis. So these are incredible medical advances, and we just need to really lean in to what we can do as public health and healthcare to get the advances to people so that we, make a further dent in these epidemics.
We can change people's lives, and that's what our goal should be. Thank you, Sarah, for our time today. Producer Dane, did we have any questions that came up for you as you were with us today?
Yes, I think since we kind of ended around stigma a bit, one of the things that came up was, Dr. Rowan, you mentioned people are going to be less likely to receive care if they feel stigma, but I'm curious too, how else have you seen kind of in the patients you treat stigma present itself even in your visits with them?
Yeah, I think one of the most heartbreaking things that I have seen in my career is when people are newly diagnosed with HIV and they blame themselves. And that is what internalized stigma does. And people will weep and say, I deserve this. And it's just so heartbreaking. And there's nothing that you can say in the moment that's going to make them realize that that's not true.
Yeah.
So yeah, I think that people have so many thoughts about what they should or shouldn't do based on what they've been told since childhood or experiences that they've had. And it is really an opportunity for us, to really see people and, just tell them that we see you and you are a deserving, wonderful person, and everyone has experiences in life. And, this is not your fault, and you don't deserve anything.
You deserve to have the highest health attainable.
You deserve good things. You don't
Yes.
deserve anything bad.
Yeah.
Yes.
What else, Producer Dane?
Great. There was some interest in talking more about the intersection around homelessness,
Mhm.
and curious what would be the best solution for intersectional care, for those for people experiencing homelessness from your point of view.
That's perfect. And I have a slide. I may have scrolled through it quickly, or I may have hidden that one in the interest of time, but some kind of more like structural things.
Okay.
We have an amazing organization called the Colorado Coalition for the Homeless, and they have a clinic called the Stout Street Health Center. They do HIV care there. They did not start out being an HIV care provider, but because people feel safe and that's a comfortable space, some people with HIV are getting their care there. And to say, no, you have to go to an infectious disease clinic is really creating an unnecessary challenge. So they have HIV experts now.
Good.
So coordinating care with partners who were already experts is so important for caring for people experiencing homelessness. And they do street outreach, and they're not really doing, I just checked with them, they're not bringing HIV medicines necessarily to start people on HIV treatment, but they're really good at strategizing how to help people through street outreach or in shelters to stay in care. Lockers make a huge difference. Help getting on Medicaid makes a huge difference. I don't know, what else, Tai?
I think that you hit those salient points. I think what's most important to understand is that that's a driver, and that we should be working with partnerships with organizations that address homelessness to really close that gap.
The other thing is we have injectable HIV treatment now. For some people experiencing homelessness, this is great because you don't have to keep track of a bottle of medicine. Others may say, well, I can't leave to go to the clinic every 2 months because I can't leave my stuff. So it's person dependent. So we don't want to assume one size fits all, but I think for a lot of people, an every 2 month injection can be a lot better. We have options.
We have options. All right.
I think another thing that people are curious about, just in your experience with patient care, Dr. Rowan, is this knowledge of syndemics and all the different factors, overlapping factors that could be impacting someone in their care. How does that sort of play out for you in your interaction with patients? It's one thing to have the knowledge of it, but then like, what does that look like when you're in patient visits and more tangibly?
Yeah, I think It depends on the scenario. So if I'm in my HIV primary care clinic, then I want to address everything as much as I can.
As much as you can within the time.
Within the time frame.
Yes.
But like that is like I'm someone's primary care provider. So I want to address the whole spectrum of their health experience. And if it's too much, then I'll have them come back frequently. If I'm in the sexual health clinic, then we're focused on sexual health and we ask questions that relate to sexual health, like about substance use and other medical conditions. And if I identify, or really it's my team there, identifies a substance use issue, we will really actively refer people to, not only substance treatment, but also give naloxone and other, talk about other measures to prevent infection. So that's one way the syndemic manifests, where I'm not going to address all conditions in the sexual health clinic. That's just not what that clinic is funded for. But the awareness is really important because there is a lot that we can do, and that our clinic is amazing at really looking at people holistically, even though they're there for one thing, and optimizing what they can do at that time. And then, I do some telehealth that is funded for hepatitis C telehealth, but I'm screening for multiple things. And I ask some open-ended questions, and I can't address everything because of that funding and the situation, but I'm definitely trying to stay open-minded and screen for as much as I can and refer for things that I can't treat at that moment.
Thank you.
Mhm.
Last thing, and I know we stopped sharing, so this, you may need to help me out here. There was a Venn diagram,
Yes.
it's focused on, or part of it was about diabetes and tobacco use as kind of syndemic factors. I think someone was interested in just kind of hearing a little more about that.
Yeah, the reason that I mentioned those two words were because when you look up syndemic, you'll see a lot about substance and HIV and STIs and hepatitis C and homelessness, like we talked about today. But other syndemics are things like diabetes and hypertension, or diabetes and poor nutrition. And those things can go have a similar Venn diagram.
So it's any health condition. Syndemics just don't refer to
Exactly.
sexual health things.
Exactly.
It's any health condition that is can cluster based upon any number of social or structural factors.
Exactly. It's sort of the interplay of social conditions and certain health conditions.
Right.
And sometimes those health conditions can exacerbate each other.
Yes. That's why understanding things like food deserts
Mhm.
in communities where you can't get fresh vegetables are important for something like diabetes and poor nutrition.
And really, even with diabetes, safe streets, traffic safety, ability to get out and walk around, get exercise, walkable neighborhoods, like these things are also really so interrelated.
We've talked
yeah.
about the ability to have walking sidewalks in neighborhoods, and a lot of neighborhoods don't have sidewalks for a number of conditions, for a number of reasons, but it does impact. It's a driver.
Yep, access to green space, like, not just weeds, real green space. Yeah.
Touching physical grass does a lot to reset one's nervous system. All right, well, thank you for joining. That is session 4 of our summer learning series. We have been happy to do this. I want to thank everyone who joined us for this summer learning series. Our director, Helen Burnside, our medical director, Sarah Rowan, Kiana Stallsworth, and Beverly Wasserman. We want to thank you all that. We also want to thank our producers, Kim Weeks and Dane Roper, for helping us out. There are a number of interns on the back end that also make all of this possible. We are so glad to have spent summer 2025 with you, and we look forward to spending summer 2026 with you. Maybe we'll start off talking about whole person wellness and trauma-informed care. Have a great day, everyone. Thank you.
Thank you, Tai.